Hi there, my name is Mike Sullivan. I'm the Program Director of Valor Medical Services. I'd like to welcome you to this presentation from our series of continuing education for pre-hospital providers. Now, before we begin, there's a few things we need to go over. First off, the information presented in this program is intended for use by trained EMS providers. Also, due to variations in protocols and scope of practice among different states, departments, and agencies, this program may discuss or depict procedures, medications that are not acceptable in your daily use. If you see something in this presentation that varies from your agency's policy, always follow your department's protocols. Also, none of our authors or presenters of this program have any conflicts of interest or financial relationships they need to disclose. We do have documentation of this on file available in our office upon request. While we do our best to make sure that all the content we present is the most current available, participants are reminded that medicine is indeed a dynamic science and thus changes rapidly. So things may have changed since we've written or compiled this program. Please always follow the most up-to-date information available. In closing, if you have any questions about this or any of our other programs, please email us at info@valormed.net. Thank you very much and welcome to the program. Alrighty, now that we've got all that legal stuff out of the way, before we get started, let's talk about coffee for a second. If you're looking for a great cup of coffee, you probably want to check out coffeebrandcoffee.com. They're an online retailer, American owned and operated. They have a wide variety of coffees, teas, hot cocos, all sorts of different flavors. They've got all sorts of organic teas. You can get coffee in bean form, ground form, K-cups, whatever your heart desires. I've had several of the different blends and several of the different flavors. Absolutely fantastic. And because they are an American-owned small business, they don't have a big warehouse, so they don't have a big supermarket sales business. They roast it, they bag it, they ship it to you. It'll pretty much be some of the freshest stuff you'll ever get. Definitely highly recommend them. And they've got a promo code out for us now. If you use promo code VALOR SDS, you get a 5% discount off any order. So you can save a little money, try some fresh coffee, see what you like. They've always got different flavors coming through on their website. Some are permanent, some are limited time only. And if you look right there in the picture, you can see they've even got, yes, double caffeinated. Definitely a winner around this office. Alrighty, now let's get to class. Hi there, my name is Mike Sullivan. I'm one of the instructors with Valor Medical Services, and I'd like to welcome you to ECG Interpretation Module 2D. This is our fifth in our ECG Interpretation series, and this will focus largely on ventricular-based rhythms, or rhythms originating in the ventricular area. Now, we'll talk about the core criteria for ECG interpretation that we apply to all rhythms when we're trying to analyze them. We'll describe criteria that would associate with the following tracings: idioventricular rhythms, monomorphic ventricular tachycardia, polymorphic ventricular tachycardia, and ventricular fibrillation. We'll also discuss and explain the clinical significance associated with each of these tracings. Now, when we talk about ventricular rhythms, there's pretty much a handful of them, and those are the big four that we just listed. Every one of these rhythms represent a significant degree of cardiac compromise, or in many cases, cardiac arrest or pending cardiac arrest. Given the fact that the intrinsic rate of the Purkinje fibers is about 20 to 40 beats per minute, if they've taken over the dominant pacemaker, the patient will likely have a rate of 20 to 40 beats per minute. Now, we know normal adult heart rate is 60 to 100. 20 to 40 will not sustain life for long. Think of the Purkinje fibers as the third string pacemaker. While it's better than nothing, it will not be a long-term solution for the patient, and in many cases, if they can't get the heart rate back up quickly, the patient will be inadequately perfused over time. So now, let's take a look at our first rhythm. As we mark out the EKG, we'll mark out 6 seconds worth. So we start from here, and then we have 1 second, 2 seconds, 3 seconds, 4 seconds, 5 seconds, out to 6 seconds. So based on this being 6 seconds worth of ECG here, We start with this complex. We have 1 QRS, 2, 3, and almost to the 4th. So we'd give this what? Well, about 30 beats a minute. Ooh, that's not good. Now, if we look and we actually measure the distance from each one of the R waves between, we'll see that the rate is fairly regular. As we look for a PR interval, do we see any P waves? Is there any way to measure a PR interval if you don't have a P wave to start on? No, not really. So without any PR interval, no P waves, so we can't come up with that. We look at the QRS width. Well, if we measure out the QRS width, we can see that it's fairly wide, goes from about here out, that would be definitely greater than 0.12 seconds, or 3 little bitty boxes. So when we look at this overall, and we look for a P to QRS, it tells us that there are no P waves, so clearly it doesn't start at the SA node or anywhere in the atria. The wide complex, wide rhythm, this would be an idioventricular rhythm, or a ventricular escape rhythm. The clinical significance of this is that the rate is actually being run and totally paced by the Purkinje fibers in the ventricles, hence the reason the rate's about 30, i.e. between 20 and 40. So we look at the overall rate and we say, well, if it's perfusing and it has a pulse, that's great, but it is not a long-term rhythm and definitely will need treatment. Now, let's look at another rhythm here. Now, looking at this rhythm, we'll analyze it using our 5 rules. We mark from this marker here, and we'll count out 1, 2 seconds, 3 seconds, 4 seconds, 5 seconds, 6 seconds. So based on the fact that we have 6 seconds, and we'll count back 1 QRS, 2, 3, 4, 5, 6. This would give us a rate of about 60 beats a minute. Sounds right. And we look at the overall rhythm. Well, it appears to be relatively regular. A couple of the gaps out toward the end here may be a little bit longer than they were in the beginning, but overall it seems to be pretty much regular in nature. So we'll look for P waves, and we can't find them, so we can't calculate a PR interval, of course. The QRS width, again, it's wide complex, definitely longer than 0.12 or 3 small boxes, and without P waves, there's no way to have a P to QRS ratio at all. So now that we've applied the rules of rhythms for this, what would it be? This would qualify as accelerated idioventricular. The reason we'd call it accelerated is it's more than the 20 to 40, so it's not a standard rhythm, an idioventricular rhythm. It would be considered accelerated. Anything between 40 and 100 would be accelerated. Now, as we look at these two rhythms, the idioventricular and the accelerated idioventricular, either one of them or a combination thereof represent significant cardiac compromise. While they may or may not produce a radial pulse, the patient will likely be hypotensive, meaning low blood pressure, possibly present with altered mental status, an excellent indication of poor cerebral perfusion. If they're not perfusing the pumpkin, many times the patient will become altered, confused, dizzy, lightheaded, or unresponsive overall. As a provider, when you're faced with either of these rhythms, you should be ready to implement either emergent pacing and consider transport to the closest cardiac-ready facility. The reason we preach that is, in many cases, the best treatment for this will be either a temporary pacer or a long-term pacemaker implant. So there's a lot more than the patient's going to actually need than can be done in some community hospitals. The next rhythm we'll discuss is ventricular tachycardia. Now, while ventricular tachycardia may sound like one specific rhythm, it may present in different forms with different clinical significances. So it's more or less a family of 2 or 3 different options. One of the key differences between this family of rhythms and the others is it may present with or without a pulse. So when evaluating a patient with any of the following rhythms, the first step is to evaluate if the patient has a pulse corresponding with the beats. If it does, great, we'll treat it like VTach with a pulse. However, if the rhythm does not produce a pulse, it should be treated as ventricular fibrillation, or VF. So, as we look at this first rhythm, let's march it out and see what we've got for a rate. Okay, we'll start from here. We'll look at the top, starting from this marker here, and we'll say we've got 1 second, 2 seconds, 3 seconds, that here, 4, 5, and 6. So in a 6-second strip, we march to here, and if we were to count back, 1, 2, 3, 4, 5, 6, 7, 8, 9, 10, 11, 12, 13, 14, 15 QRS complexes in a 6-second cycle. So that would give us a rate of what? About 150 beats a minute. Does that correspond with what we're being told? Well, it says 149, so yeah, about 150 beats a minute. Now, looking a little further, do the QRS complexes all appear to be regularly spaced out? Is it a regular rhythm? Yes. When we look for a PR interval, does anyone see P waves on there? Because I don't. No P waves. And the reason, again, we don't have P waves, it's originating in the ventricles, so the atria is not firing. Nextly, we'll look at the width. It's a wide complex rhythm. That wide complex, again, gives us an idea that it's going to be greater than 0.12, which confirms that it's a ventricular arrhythmia. And lastly, when we're trying to determine the QRS, or P to QRS ratio, we're unable to do so. So we look at these two factors here. We have a wide complex rhythm. We have 150 beats a minute. Well, wide complex would indicate it's ventricular, and over 150 beats a minute would be tachycardia, so there we are. We have ventricular tachycardia. Now, this is a specific type of ventricular tachycardia. If we look closely at all the QRS complexes, they appear to be fairly similar, almost identical, many of them. So that would mean they've got one form. So this would actually be called monomorphic ventricular tachycardia. So when we're looking at for monomorphic ventricular tachycardia, it would be a rhythm that originates in the ventricles, has a rate over 100 beats per minute. That would make it ventricular tachycardia, described as monomorphic because all the complexes appear to have the same form. While it may produce a pulse, it may also degrade to the point where there is not a pulse. The presence or absence of a pulse will determine how it's treated. If it has a pulse, it's monomorphic VTach. If it does not have a pulse, we'll treat it as VFib. Now, let's move on to the next ECG here. Okay, that's kind of different. What do we see? Well, first let's do some counting. And we'll go from here, and from this ECG here, we have 1 second out to here, 2, 3, 4, 5, and 6 runs us out to there. Counting back, 1, 2, 3, 4, 5, 6, 7, 8, 9, 10, 11, 12, 13, and pretty close to the 14th here. So about 13 to 14. So if that's 6 seconds, it would translate out to 130 to 140 beats per minute. Now, does the rhythm look to be fairly regular? Well, when we look at it closely, might be a little bit irregular. Some of these gaps appear to change, and also the forms appear to change. We look for a PR interval. Well, there's no real PR interval because there's no P waves. When we look for the width of the QRS, well, it's wide complexes, and they vary in form greatly. If you look, these complexes right in the first section here don't look much like the ones in the middle, and certainly don't look like the ones down here. So changes in form, no P waves, so it would definitely be ventricular arrhythmia. There's no P to QRS ratio, so again, it would be a ventricular tachycardia. However, it's a different type of ventricular However, it's a different type of ventricular tachycardia than the one we had before. This is polymorphic ventricular tachycardia, where poly is many. This would be many forms. You may also heard it called torsades over the years. Now, this variant of VTAC is very similar to its monomorphic cousin, the significant variation in the forms of the complexes. In some of the cases, it will present with a prolonged QT interval. This would actually be torsades de points, or the turning of the points. Regardless of the cause, VT, ventricular tachycardia, is a situation that must be addressed urgently. Typically, we'll address it with antiarrhythmics if it's relatively stable, or if it's pulseless, we'll address it as VFib. Going forward, let's look at this rhythm. I can't really come up with QRS complexes of any kind here. I don't really have any kind of P waves. It's sort of all over the place and squiggly and chaotic and garbagey. What would this be? Well, we would consider it to be ventricular fibrillation, or VF. Now, the presence of VF normally indicates the patient's in cardiac arrest. If this rhythm observed as an initial rhythm, patients should confirm that it correlates with the patient's presentation or condition. This would be confirming that the patient is unresponsive, pulseless. If we have that as initial rhythm and it doesn't correlate with the patient's condition, make sure you don't have a loose ECG lead or a wire gone bad or some type of electrical interference. We want to make sure before we treat VF that we actually have VF. I know that sounds simple, but it's always a good thing to fall back and double check. So let's go back to the rhythms we've covered in this module. We had our idioventricular. Normally has a rate of 20 to 40 a minute. Has that wide complex QRS. No P waves, no PR intervals, no P to QRS ratios. Accelerated idioventricular is much the same. The only key difference is the rate is a little bit higher, thus accelerated. It's between 40 and 100 a minute. If we go over 100 a minute, it would be ventricular tachycardia. Now this could again be fallen to the monomorphic or polymorphic side, and they're treated slightly differently, but we're not really going to get into that today. And lastly, VFib. VFib is a chaotic arrest rhythm showing the quivering of the ventricles with no organized activity of the heart or of the electrical system whatsoever. In closing, generally speaking, the family of rhythms will be indicated by wide and erratic QRS complexes. While there is a wide variety of causes and etiologies, this family of rhythms represents some of the most critical patient presentations the providers will encounter. In many cases, treating this effectively and quickly will allow us to restore the patient into a sinus rhythm or pace them to overdrive, to do something to get perfusion back and maintain perfusion in the field and get them to somewhere where their case can be managed more effectively. Hey there, I'd like to thank you all for stopping by, checking out our video. If you want more information about our company or any of the stuff we do, you can check out our website. If you need EMS continuing education hours, we do have our online education platform posted up there. Also, we have our email address if you have any questions. You can find us on YouTube, Facebook, Twitter, and Rumble. We maintain channels on all of those. Also, please like, share this out to your friends, subscribe, help support the channel, and we'll keep putting more videos out there for you. Oh well, enough about that. I know what I'm up for. Time for a cup of coffee. Y'all have a great day. Be safe out there. Bye.